So our next speaker is Professor Gautam. I think it's Gautam doesn't need introduction. He has been here for over 2 decades now, and I will hand over to him.
Thank you, Chandru. So, sorry for this somewhat boring title. The word social determinants of health may not ever have been spoken before in this hall, but they represent my more current interests at the moment. So, it's actually wonderful to be back here after a long time. I think it's at least been about 6 years since I've given a talk in this hall, 5 to 6 years. And IMSC was very important to me in my own career in basically accommodating the range of stuff that I worked on. Probably I was hired for something else, but began to shift to something completely different. So when I came here more than 20 years ago, I was really a condensed matter physicist and statistical mechanic working on magnetic properties of superconductors. Along the way, I moved into thinking about biophysics and computational biology. And we started the computational biology group around 11 years ago. And at that time and later, as Sandhya said, I worked on motor transport, chromatin organization, cell adhesion, collective effects in cell motion, etc., etc. But over the last roughly 5 to 6 years, I've shifted almost full time to thinking about health and health policy. So I want to tell you the question is why? Why should one even begin to think about it? And what is the particular relevance that this idea has? So you can pose it in this question, why should an institute that's traditionally devoted to mathematical and computational sciences and theoretical physics of really all sorts, as you've seen here, even bother to think about disease? And sort of the manifestation of this, of course, is the computational biology group, where a significant number of people in that group think about disease in various forms, as well as the new center, the IMSC Center for Disease Modeling, a bunch of colleagues even outside the computational biology group who are interested in questions of disease. So I want to tell you about 4 becauses why this really ought to be the case. One relates to how we think about disease in modern times as opposed to 50 or 100 years ago. And this is a sort of something that I extracted from a talk I went to about a month ago by Srinath Reddy, who was the founder of the Public Health Foundation of India, at the inauguration of some new center in Delhi. And he said, we require interdisciplinary approaches as well as an understanding of complex systems. Now, this is a line that could have been taken out of one of Sudeshna's papers or any one paper on complex systems. But it's a bit odd coming from a public health expert says that, look, we need to look far beyond what we are doing. And we need to look about how complexity is part of the way we analyze public health, the way we think about public health. The second is that traditionally, actually, IMSC is very well positioned to do this. And this is something that may not be generally known. But we organized a series of meetings, Shitabra and I, starting in 2006. So 2006, 2010, 2 meetings in 2015, all centered around diseases and thinking about diseases. And in an effort to bring together a community across India, people working in public health, epidemiologists, public health scientists, modelers, etc., just to see how to get them talking to each other, where the gaps lay in the data. So these are the posters that came from that time. And Rahul, in more recent years, has looked at other types, has organized other types of meetings looking at different Bayesian questions in disease modeling. Pinaki and Dheeraj are from the theoretical physics group, again with an interest in diseases and disease modeling. So we've come at this from many different angles. And so that's why I say that we, unlike pretty much any other Indian institution, is well positioned to do this because we've been doing it for a long time and thinking about these questions for a long time. So my third because is because models are tools to frame good policy. And if you want to look at models, the right people to talk to are really theoretical physicists and no one else, because they really understand how to take extremely complicated, miserable looking biophysical, physical, etc. situations, condensed matter physics, etc., and convert them into things that are tractable. This is a skill of its own kind, and that's essentially what we teach our students at IMSCs and all places that do varieties of theoretical physics and modeling. We teach them how to think about models, how to take complicated things and think about them in simple ways. And the last point is, of course, because India needs it. And this refers back to yesterday's panel discussion where we discussed a whole range of different items, and health was certainly very prominent among them, about how the need for data about health, for thinking about health, for collaborations between institutions such as VHS, IIT, us, Kalpakam, etc., were all very important. Where all of us can contribute, all with our training, whether physicists, applied mathematicians, or computer scientists, is really towards methods and better models for improving public policy. Because whatever you do, whatever papers you write, none of this makes a difference until you can translate it into something that really saves a life, or can potentially, whether it's something as simple as reducing traffic deaths in Tamil Nadu or across the country, that requires specific actions, specific policies, And that's where the job of better models that can tell you what might be a good policy, what works and what doesn't work, become very crucial. And of course, there are many things to do purely on the clinical data side that has to do with Indian data. We often rely on models that have been developed for the West, for Western population, the so-called weird population, WEIRD standing for Western, educated, etc., etc., etc. But we don't have enough that is specific to Indian population. The Indian population are very different in many cases. In fact, we're just realizing that the fact that you cannot use clinical data extracted on purely men to talk about problems of women's health, because they do respond in fundamentally different ways to medications, etc. So we have to expand the way we think about health, and these are different ways in which we should actually begin to look at it. So I want to talk very quickly about my work in multiple models, and not really because I want to explain these models to you in any great detail or anything. They would all be separate talks, but because I want to give you a flavor of how one thinks about problems in this field, what one does, what are the sorts of problems that one is thinking about, and why they might be interesting, why they might be useful. So I'll talk about compartmental models, including one that was developed really out of IMSC, University of Pune, ISC Bangalore, etc., a bunch of collaborators. This came out of this Indian scientist response to COVID-19 that was set up by JAM and others. And that is again a remarkable effort of purely voluntary effort of many scientists coming together to look at public explanations regarding COVID-19, modeling groups, debunking of hoaxes, etc., that came along with that. And the last thing I'll talk about is a model called BharatSim that I've been working on for the last 2 years. So the first wave of COVID-19 in India, remember that COVID came to India around, as best as we know, around the 30th of January of 2020. And then there was this sort of stringent lockdown that happened here, which you can see over there at that point. Then the little box that you can see, and this rise of cases that peaked around the September of 2020 and then came down again until it was fairly low by the middle of February of 2021, at which point it took off again. So there's some interest in understanding the first wave of COVID-19 because that sets an initial condition for what happened with the Delta wave. And how many people were infected at that time, to what extent did that infection, a prior infection, provide protection against the Delta wave? Could the Delta wave have been worse? How do we benchmark our techniques and methods on something that we have that is retrospective, that goes back to the past, so that we can improve them for current use? That's what we were looking at. This is what the model looks like. This is just a set of boxes that describe states. So the question here is how many people are mildly infected, severely infected, hospitalized, susceptible, etc., etc. You can think of the basic object that you want to model as a number of people in each of these little boxes or compartments, and people move between compartments. Someone who's susceptible can be infected, someone who's infected can move to a severely infected or mildly infected or asymptomatically infected. And we write down equations that describe this. Of course, it's much more complicated than that because you have to worry about age structuring. Each compartment is broken up into the number of people in the age group of 0 to 10, 10 to 20, 20 to 30, etc. We worry about how these people interact. So we take social data that says people in the 80 to 90 age group tend to interact more with other people in the 80 to 90 age group than they would, for example, with someone in the 30 to 40 age group. So that's where the social data also figures. And this then gives you fairly complicated models that you can write down. There are a large number of equations with many parameters. And you have to do as best a job as you can with understanding those parameters and what they mean. So we looked at multiple Indian cities, multiple Indian states, India as a whole, etc. But here's the bottom line. We estimated that about 35% of the population had been infected at the end of the first wave of COVID-19 in India. That's a somewhat conservative number because if you look at the IIT Kanpur model, so to say, that number said 60%, 70%, etc. But actually that doesn't seem to be true. The lower number probably is more accurate. This also tallies with what we know from other types of more biological and clinical measurements. We estimated that about what's called the infection fatality ratio, about 0.1. This is again conservative. Some numbers are larger than these. And then if you look at what is the estimates of death under counting, we said you were counting only 1 death out of 2 actual deaths from COVID-19, a little more than 2. But that range could be anywhere between 2 and 5. And we took a somewhat more conservative point of view regarding that. And we looked at the undercounting of cases. How many cases were there actually there of COVID-19 infections versus how many did you actually manage to detect? And towards the end of the pandemic, we were detecting 1 in about 20 cases, whereas early on it was more like 1 in about 100 cases or 120 cases. So these are all things that you can extract from a mathematical model treatment that you can then attempt to relate to what people can measure clinically to look, for example, in a serosensitivity assay and so on. So that's where the policy came in. So among the things that we did was to advise a particular state government. We spoke to a bunch of state governments, but with the Andhra government was where we worked most closely to understand on a week-to-week basis where cases were going. So we said, how many do you expect 2 weeks from now, 3 weeks from now, etc. How many hospitalizations, how many deaths? And we would do this exercise. We met very regularly with them on a weekly basis, and we would try to push this number a little bit, never projecting too far in advance. But this actually turned out to be very useful because they slowly, from a position of distrust of mathematical models and so on, they moved to a position where they were actually asking us, can we use your models, can we use your numbers to predict, for us to decide what our drug procurement strategy should be? How much of antivirus should we get? How much of remdesivir should we order? And that was actually useful. Again, this is the point that I'm telling you about the interplay between models and policy. Once you begin to trust a well-benchmarked model, you can then use it to decide major financial decisions because this is a large sum of money. How much do you need? You do not want to order more drugs than you might actually need in that particular situation. So that's where reasonable, credible estimates of what might happen in the future become very important. Here's an example of a much more complicated model. So this is the example of somewhere where you have people who've been vaccinated, have not been vaccinated at all, vaccinated with 1 dose of vaccine, vaccinated with 2 doses of vaccine. And all of these conditions are people with 2 doses of vaccine. What is the likelihood that if they're infected, then they might well end up in hospital? With 1 dose of vaccine, how does that number change? If you're poorly susceptible, how does that number change? If you're in the background of a prior infection, you're already starting from a situation where 30% of people have already been infected. How do these numbers change? So now you understand how complicated the situation gets because many of these numbers have to be extracted from data that is available from other countries, from very, kind of slipshod, not very complete data for the Indian population as such. But again, you can use this to, for example, we use this to understand why is it that cases in children in Andhra Pradesh didn't go up and schools were reopened. Why is it that the Omicron wave was a milder wave overall in terms of hospitalizations and earlier than the Delta wave, for example. Here's something that we did again about 1.5 years, 2 years ago, which is try to understand the nature of testing in India and what might make for good policy in terms of testing. And so just to remind you, all of you know this, we use 2 tests for COVID-19 in India. One is a rapid antigen test, an RAT test. It's called a point of care test. You can take it and you have a result in about 10 to 15 minutes. And the other is the RT-PCR test that it takes typically 8 to 12 hours to give you a turnaround on that. It's more accurate relative to the RAT test, but it's also more expensive and there is a delay. So how do you now compensate between both of these things? A test that is cheaper, easier to distribute, real-time answer versus something that is delayed in when it returns its result and is also more expensive. So questions here are questions for policy. How much should you be testing in a population? What is the optimal mix? Should you do 20% RATs and 80% PCR? Should it be the other way around? What's the right mix and how does the economics of that mix also make a difference? What does it depend upon? And as you will remember, many state governments and central government negotiated very tightly with drug manufacturers to bring down the prices of the PCR tests relative to the RATs. So then given the price differential between this, how does that optimal mix of different tests, how does that change? So this is again stuff that we looked at, and here we used a network model where you try to construct little communities of people with homes, etc., in hospitals, workplaces, people move between homes and workplaces, and then you look at rules. When you test someone who is positive, who displays symptoms, do you quarantine them, do you not quarantine them, do you isolate them or not isolate them, do you quarantine their families, do you not do that? What is the cost of these tests? Given you change the nature of the test between RAT and PCR in various mixes, how do things change? So this is about 20,000 people, make a nice model community with different houses of different household sizes, etc., different workplaces, and you can put in whatever information you have that is social information and wrap it into these models as well. So that's what disease spread across that network looks like. And once the dark parts there are home locations, work locations that are marked, and this generates for you the sort of typical picture that you see below there, which is an epidemic curve, number of infections going up and then coming down. And you can now vary the parameters that you have inside this model. You can change the quarantine procedures, you can change the testing rates, you can look at non-pharmaceutical interventions such as masking, and then ask how does all of this make a difference? And what is the right way to think about policy in this background? So long details there, but this work was picked up by Eureka to get circulated around the world. The bottom line basically was that you can actually get away with not so good tests. For example, almost with all RAT tests as opposed to PCR, provided you test more. And we described exactly where the trade-off lay. How much more should you be testing for a full RAT regime to be equivalent to a full PCR regime? We looked at then school closure, so we did some work for the WHO, which was interested in this question of when should you open schools? When should, in India, for example, had among the longest periods in which schools were closed in the country. And this was an intense debate among people who thought about school education and people who said that it seems politicians like to close schools because then they will not be held responsible for any increase in cases in children. And of course, cases in children is something that all of us as adults worry about, all of us who have families, that you don't want your child to go to school and fall ill. So that's an easy way out. But the difficulties with that is keeping kids outside the formal education system for a period of 2 to 3 years has a long-term effect. And this effect is only amplified as they grow older. And so there were these two opposing camps. And then the question was, okay, we are now at India in 2021 in August. Let's assume that the past year children have been out of school. What happens if you reopen schools now? What are the consequences on different age groups that you can actually look at? So we again worked with these models. We worked with Asian-based models to look at a bunch of things. What happens in low-risk individuals between 0 to 18? What happens in at-risk individuals who have not been vaccinated, for example, in a higher age group? And basically we found out that, look, we really should open schools at this point. You do expect a small increase in cases in children, but it's not likely to be significant and certainly not likely to send large numbers of kids to hospital. So that's again the point where we wrote about this in the press, so that because we wanted this to be advertised a little more, this sort of suggestion that this is the right policy to take, rather than just to the WHO to whom we were submitting a report. So we wrote again an op-ed on this and spoke about this in a bunch of places. And again, I want to illustrate the relationship between the nature of models, the nature of how one presents these models to people who make policy, and also the need to communicate to the public, because the public influences politicians, influences policymakers, and you have this circle to complete. So the last thing that I want to talk about, and I'm glad I'm not taking too much time, is a general question that I want to pose to you. Suppose you had all of the data that you needed about a population, all the social data, all the personal information, health information, etc. Would that help you model the spread of disease any better? That introduces a large amount of complexity into how one thinks about diseases, but where's the trade-off there exactly? The other thing that is important is that it enables you with the social information to understand what is called the social determinants of disease. We all know from our experience of the first wave of COVID-19 in India that this struck different populations very differently. So migrant populations, poorer populations, the slums of Dharavi in Mumbai had disease levels of had seropositivity of 80% or 90% compared to the high rises that were next to them, where these numbers were about 20%. And that imbalance got righted in the second wave, in the Delta wave, which pretty much spread very efficiently throughout and infected everybody almost to the same extent. But why is it that disease affects some populations more than other populations? It's very well known in the US, for example, where black populations, minority populations tend to have much more higher rates of disease than regular white populations, relatively affluent populations in the suburbs of cities of the US. So where do social factors play in with disease spread, and how does one understand that? And the complexities here is that, of course, India is divided in many complicated ways. We are divided by caste, we are divided by economics, we are divided by huge levels of income inequality here. How does all of that play into how one thinks about disease and how disease spreads? If you understood that a little better, you could target your interventions better. You could understand which is the segment of population which we should immunize on priority versus other populations, because you know that disease would tend to spread more fast in those populations. So overall, for the community, it makes sense to look at these specifically in advance if you had that kind of information. So what I've been doing here is working on a class of models called agent-based models. And this is an idea called Bharatsam. The idea of Bharatsam actually comes back even before I sort of physically left math science, which is to think about very large-scale computer simulations of agents. And an agent is a computer object that is basically represents each individual in a population. We can now think about realistic agent-based models because computers are now so much faster than they used to be 20 years ago. We can think about simulating 50 million to 100 million people. And it's called Bharatsam because there was this vague idea that someday we might be able to do 1.3 billion people. But realistically, that doesn't really make sense. What we're more interested in is disease spread in communities and cities, at most it's states, which are somewhere between 70 million in a reasonably sized state, all the way up to about 230 million for about UP, for example, which is a large number. But here, so this is now available for people to download. The paper behind Bharatsam is still currently being written and is being there, but anyone can download this and try it out on their own. So it's a computational model that simulates disease spread among agents. It's a framework, so it can be adapted to any different type of disease that you actually want to study. You can work all the way up to we've tested it up to about 50 million agents. You can potentially go up to 100 million agents in there. You can put in realistic geography using a geographical information system. And then there's a lot of work that goes into understanding a synthetic population for agents. Now, when I say that, look, if I wanted to ask you for your personal data, that's something that is very personal and private to you, and you do not want that exposed to me in any way, nobody would. So then the question is, can you develop a description of the agents that is relevant for disease, but is in a sense statistically describes the entire population? It may not describe any single individual accurately, but it's a good statistical mix. If I ask what is the male to female ratio here, what is the distribution of family sizes, what is the distribution of incomes, what is the distribution of educational achievement, etc., that should come out of the synthetic population that I create out of these agents. So this is an extremely difficult problem because it really involves integrating a whole bunch of different surveys, the IGDS, the various types of medical surveys that exist, putting them together and then describing this whole complex of 1 million individuals in a way that really represents what the statistical properties of that population look like in real life. So there are three parts to this. One is the creation of the synthetic population. The second is the framework that enables you to do these large-scale computer simulations. And the third is the tool for visualizing the data that comes out of it. So you can do this at different scales. You can do the same thing that we did with the school reopening or the tests, etc. You can work at the level of communities. You can work at the level of districts. If you want to lock down a district locally, you can ask what are the implications of that. You can work with states and cities, and you can work even with countries where you can worry about migration in country, migration from outside the country, etc., etc. So here's some examples of Pune city, where you can study using BharatSim. This is a synthetic population constructed using the IHDS, the census of 2011, a little more modern data from the city about the census, coordinates for all the villages. So these are different parts of Pune that are marked together over here. And the colors here represent the change in the number of infected cases across day 0 to across day 41. The advantage with doing these models is that you can do very specific interventions. You can say, what happens if I shut down the city? What happens if I close public transport? What happens if I close all the schools? What happens if I open some schools in some areas, in some wards, but leave them closed in other wards? What happens if I cut major transportation links, for example, bridges between one part of the city and the other part of the city? By being able to work in this granular way that's very connected to an underlying geographical information system, you're able to make all of these micro-level planning changes and then ask which policy works better, which combination of policies actually works better. You can even tie this to economic decisions that if I belong to a low economic class, such that a lockdown, I will have to violate a lockdown in order to feed my family, feed my children, basically just survive from day to day. It allows for people who can break the constraints imposed by curfew or a lockdown in order to go out. It allows for essential workers who may potentially contract the disease and move around spreading it to other people. These are the things that you can do with models that are focused on individuals. But the price you pay, of course, is these become much more complex and difficult models, and you cannot write down equations for them anymore. You have to solve them on a computer. This is, again, Pune across multiple wards and one way of simulating it across 180 degrees. And there's a movie here for Mumbai which may or may not play. Yeah, okay, it does play. That's, again, the changes in the disease across these different wards of Mumbai. You can also look at questions of one variant followed by another variant. And this example on the top here, so this is for Pune with a population of about 3.2 million people in the area that we studied. So this is one variant coming in the beginning, and then a second variant over here. But now you can say that, look, suppose the first infection gave you some protection against the second one, and you can vary that level of protection between 20, 30, 40, 50%. This is what you would get in terms of the reinfections over here in the second wave of that disease. And you can do much more complex things than this. It's just an example for you. So what I've been emphasizing is that there are a variety of models with many different types. Models are tools to explore counterfactuals. Real life went along in one particular way, but you can say, had we done this or had we done that, what might the alternatives have been? And that's a good way of thinking about future epidemics or future pandemics of disease, because now you will understand how to explore different alternatives at different stages. Agent-based models, I think, are the most granular, the most detailed. It's hard to improve upon this particular approach to this. It also allows for people to modify their behavior. As you hear about cases in your neighborhood increasing, automatically you will tend to stay inside a little more, you will tend to mask up a little more. The nature of behavior modification is very hard to put into models. But that's something that one can do with this type of models as well. We need data from India, both clinical, epidemiological. I'll talk a little bit about that as I finish. And as I said, complex systems approaches, interdisciplinarity is all very core and fundamental to all of this that I described to you. The last point is that new types of models. Infectious disease modeling has been around for 250 years. Networks, the importance of networks has been understood probably for the last 30 to 40 years in these particular contexts. Agent-based models, relatively new. They first turned up in economics and social sciences and then began to be used they turned up in computer simulations that you use in making movies, for example. And now the importance for disease is being realized over the last 10 to 20 years. But are there better models? How does one think about these? Can one do all the operation of renormalization that you think of in quantum field theories? Is there an analog that's useful in thinking about how to take models, bootstrap models from the level of 20,000 to 100,000 to the very large numbers that you might actually want? What are the technical details that are there? And this is again something that people who think quantitatively and mathematically about questions like that, because finally these are questions about large numbers of interacting variables, which is really what statistical mechanics is all about. So are there new methods that we can introduce that are not natural at all to people trained in the conventional frameworks of public health that might be useful to questions such as this? We've been looking at these questions of social context with groups at AIMS, and again looking at a particular population in North India, a large group that AIMS studies. How do people interact across seasons? Are there more interactions during the wedding season versus summer versus winter versus political campaigns, etc.? Can we tease from this out of how, for example, influenza changes across different waves in these particular study populations? We can use this to improve our synthetic population models, make them more accurate, and supplement them with additional surveys on these areas that are actually known. And of course, clinical collaboration is something that's also very important. We work at Ashoka, we work with a bunch of clinical collaborators, including Max Hospitals, IGIB, etc., the Sharma University of Health Sciences. Again, with this idea that we need to understand the Indian population and how disease spreads in the Indian population. And beyond a point, what we know about Western populations is really not relevant. Our genomics is different at a fundamental level. Even between North, South, East, and West, we are different at a fundamental level. Our microbiomes are different at a fundamental level. These are things that we need to understand about India before we can proceed to understanding about health in India. Here's one example of the complexity of thinking about this problem. So this is the INSACOG. INSACOG is this government organization that is a consortium of many laboratories that collects genomic data and tells you which variant of COVID-19 or SARS-CoV-2 is currently. So right on this side is the most, on the right-hand side is the most current mix with BA 2.75, XBB, etc., etc. So now the questions about disease modeling in this population have now become much more intricate. Essentially, the sort of question that you want to ask is, if I contracted COVID-19 first in the first wave, then in the Delta wave with a mild way, and I got vaccinated, and this particular variant is there, what is my susceptibility to severe disease in that context? These now becomes much harder questions to answer, and of course even the data here are somewhat questionable because they finally a very limited sampling with a variety of COVID-19 cases that are in the country. But this is really all that we have to work on. And one part of it is just improving this level and quality of data. We've been looking in the past at how to connect individual level response that really comes from your genomics to how you might respond to, for example, a novel infection of influenza here. And as I said with COVID-19, the question is how do you connect prior exposure, hybrid immunity, etc., from a combination of vaccinations and an infection to clinical outcomes. And that's where this sensitive dependence upon numbers comes in. It's easier to do this with agents than with the other methods that I described. They just get very complicated. But philosophically, that's the sort of question that we now try to answer. We're trying to approach this. And as you can see, this is a very different and very difficult job. So this is, I should thank a bunch of people here, and there are many names that I've already left out of here, but the group of people here, including the INSC names, were people responsible for the incisive model. All of my work with the school reopening, with the testing, etc., was done with this group of people here, over here, including Sandeep Krishna, Philip Cherry, and Brian Wall, etc. Farina over here has a poster outside which describes our work on vaccinations and Omicron. All of the Bharat Sim was actually developed in collaboration with a computer company called ThoughtWorks, with Harshal Hayatnagarkar leading them. So it is really, if you need to write good code, you need to go to experts in writing good, efficient code. It's not something that we are necessarily trained to do very well. Debayan Gupta is a computer scientist at Ashoka who's been working on the synthetic population. Of course, AIMS, BMGF, Rajesh Sundaresan, etc., and this bunch of people here have all collaborated with us at various points. So that's all I really had to say, but let me just summarize my basic point. So as a theoretical physicist, trained as a theoretical physicist, I've come a long way. I began with models thinking about technical issues in how do vortex lines enter superconductors, how do muons interact with them, how does this turn up in an experiment, what is the vortex class, what is the peak effect, etc. But around, I guess, about 15 years ago, the whole question of what is it that theoretical physics can do for society, it became interesting to me and important to me. And really the shift towards thinking about health, biophysics, etc. is part of that general question. Where is it that we can help other sciences? Where is it that we can help thinking about a completely different set of issues? And still, I think there's a lot to do here. And I think this, to think about health is just one example of thinking about policy in general and using models to think about policy, computational models, analytic models, etc. And for people like you and me to be involved in issues and questions such as these are, I think, important for the future. We are still a small scientific community, all said and done in the country, but no one will solve our problems for us. We need to engage with them. We need to especially think about policy. That's again, it's not enough to write technical papers that no one will read, or maybe 5 friends will read and someone will cite because there is something of technical validity in there. But if you want to do something that's really impactful, you need to think about how your work impacts policy and how that policy will impact people in the long run. And I think people who think quantitatively are really required. They require the level of training, they require the level of actually doing the stuff that needs to be done in many of these questions. That's all I had to say. Thank you very much again to IMSC for this invitation to come back home, if I might say so. And it's wonderful to be here.
Thank you very much, Gautam. So it was a very interesting talk.